welcome to our NephCure U webinar today on COVID-19. Today is going to be an update on what we now know and maybe what we're also still learning as this pandemic stretches on. My name is Kristen Hood. I'm NephCure's Executive Director for Research Engagement, and I'm going to be your moderator today. Before I introduce our speakers, I'd like everyone to know that we will offer a Q&A session. So feel free throughout the webinar today to go ahead and enter your questions in the Q&A button down in the Zoom toolbar down below. We will answer as many questions as possible at the end. This webinar is being recorded and will be posted to NephCure's website as a patient resource under educational programs. I'd like to give a big thanks today to NephCure's COVID-19 Medical Advisory Committee. When this pandemic really started and we started getting a lot of questions to us here at NephCure around the virus, around the infection, and then around vaccines, we formulated this wonderful medical advisory committee. And so I'd like to thank them for their participation in helping us here at NephCure give you the most informational, up-to-date education on COVID-19. People on this medical advisory committee is Dr. Bill Smoyer from Nationwide Children's Hospital in Columbus, Ohio, Dr. Elaine Camille from Cedars-Sinai in Los Angeles, Dr. Sina Naruzzi from Loma Linda in Loma Linda, California, and Dr. Kirk Campbell from Mount Sinai in New York City. So thank you so much to all of them for helping make this possible. I'd also like to recognize our sponsors who help make programs like this available to you, and that is Travere Therapeutics, Goldfinch Bio, Pfizer, Mallinckrodt Pharmaceuticals, Vertex, Boehringer Ingelheim, and Natera. And so now I'd like to introduce you to our speakers. Dr. Priya Soni is an assistant professor of pediatric infectious disease at Cedars-Sinai Medical Center in UCLA. She's a clinician who cares for children with complex infections, including those who are immunocompromised. Additionally, she's a clinical researcher who studies the role of intestinal permeability, gut microbiome, metabolomics, and host immune responses during Kawasaki disease. Since the start of the pandemic, her academic focus really has shifted, and she's become a key leader in the Cedars-Sinai response to COVID-19. Her research focus has expanded to better understand COVID-19 in children through her involvement in several collaborative studies, including an NIH-funded PRISM study to evaluate the immune systems of children who have contracted MIS-C, which is the multi-inflammatory syndrome in children, and after acute COVID-19 infection. She's also involved in a collaborative study with UCLA evaluating clinical outcomes in mother-infant pairs affected by COVID-19. So this is amazing that we have Dr. Priya with us here today. And Dr. Kirk Campbell is a longtime friend of NephCure. He's a professor of medicine, vice chair for diversity, equity, and inclusion, and the director of nephrology fellowship program at Icahn School of Medicine at Mount Sinai. In addition to treating patients with kidney disease, Dr. Campbell leads an NIH-funded research program focused on developing new therapeutic interventions. He actively participates in clinical trials, testing novel agents for primary glomerular disease. He is a past president of the New York Society of Nephrology, a member of the board of directors for NephCure, and a member of the medical advisory board of the National Kidney Foundation serving Greater New York. So with that, you can see that we have got a star-studded team here today. And with that, I'm going to turn this over to you, Dr. Soni. Thanks for getting us started today.
Thank you so much, Kristen, for that warm welcome. And thank you all for being here this morning/afternoon, depending on what coast you're joining in from. I'm going to start sharing my slides. And there we go. You guys can see this okay?
Yes, perfect, thanks.
Perfect. So I wanted to, oops, let's go back for a moment. I wanted to kind of start by giving the group an update on COVID-19 and children. Where are we now in comparison to the start of the pandemic? And then highlight the study trial on the Pfizer vaccine in the younger group, the 5 through 11-year-olds, that just came out just last week or the week before now. And so this is kind of going to be the highlight of my talk. And so I'll take you through. So just to kind of give a little bit of a background on COVID-19 in children, there have been up to 6.6 million children that have developed this infection. And children less than 18 years old make up 16.8% of all cases as of November 11th. And this number is rising a bit as we're looking week by week and studying these children. As of last week, there were 122,000 children with new cases reported. And so that number is about 27% of all of the weekly cases in the United States. And that's huge. I'm going to show you how that's been a bit different than before. I'm so sorry, my screen. Okay, so if you look to the right, you can see the graph, or the, I guess, map of the United States, where you have cumulative cases of COVID-19 in children. The darkest states in navy blue represent the 10 states with over 200,000 plus cumulative cases in children. And this includes the state that I'm calling in from, which is California. If you look at kind of the trends and increases, there are certain states where the numbers are going higher in children. And previously with the Delta surge, we had seen in the Midwest, Texas, Mississippi, Alabama, some of those states were heavily hit with children with COVID-19. And right now at present, it seems like the Northeast, as well as some spots in the Midwest and Alaska, are primarily affected. So here we have a national data graph of the cases in kids added over the last few weeks. And this data is all taken from the American Academy of Pediatrics in conjunction with the Children's Hospital Association. So you can clearly see that where we were before in the pandemic early on is very different than where we are now, and even much more different than where we were last winter when we saw our surges in December and January. So the peaks in children now far outnumber the ones that we had ever seen before. And I think this is because the virus is just kind of running out of hosts, novel hosts to replicate in. And so you can see here, as of last week, this 122,000 number is slowly starting to creep up from the peaks that we saw with Delta variant in September and October. And here we have hospitalizations. So I know there was a lot of chatter about how children are not affected and they're really not being hospitalized, but that's just untrue. When we look back in time and look at the hospitalization rates by age group, you can see that the kids that are 0 to 4 years old have had the most recent peaks in hospitalizations with the Delta surge. And then that was also followed by the 12 through 17-year-olds, which interestingly, that's the group that did have the vaccine available over the summer. So we're gonna have to see how these trend lines play out. But I just wanted to put this here because it is really compelling to me to show that the hospitalization rates for children have started to trend upwards. And here's another compelling slide. This is cumulative data comparing the COVID-19 hospitalization rates in children ages 5 through 11 compared to some of our prior flu seasons. We know that every year the flu has been a big deal for children, which is why we really push for them to have their annual vaccinations. And if you see the yellow line here, this is the COVID-19 hospitalization rates in this age group compared to the influenza rates in the prior years, 2019 to 2020, and then the green line representing the 2018 to 2019 season. So you can see that we're slowly going to quickly cross the thresholds for hospitalizations of pediatric influenza. Last year, because of our masking and some of the habits that we had with social distancing, we had barely any pediatric hospitalizations due to influenza. So we're going to see how this plays out, but I just wanted to put this up here for context in comparison to influenza. And here we can see that the children that are being hospitalized in the 5 through 11-year-old group, looking back over data from March 2020 to August 2021, the top few reasons, or the underlying medical conditions rather, these children have include chronic lung disease, obesity, neurological disorders. And so where do our kids with renal issues fall into this? They, looking into the data a bit more, fall under this other condition. And so about 9%, looking back at hospitalizations in pediatrics, 9% of these kids fall into the other condition category of immunosuppression or other nephrotic related issues. And there's a disparity seen among children that we have noted in adults as well. So children that are hospitalized with COVID-19 tend to have backgrounds. They're Black, non-Hispanic, or Hispanic, American Indian, or Alaska Native. So these children are disproportionately affected by hospitalization than their other peers. So in terms of deaths over time, this number is variable from data source to data source, but we have nearly 800 cumulative deaths as of end of October since the start of the pandemic in children. And of course, that number is a very small fraction of all of the kids that have gotten COVID-19, that's 6.6 million. However, this is a huge number, and I'm going to show you how this compares to other causes of death in children. But just bringing it back to our influenza comparison, kids that have died due to influenza-related complications were much less than the numbers that we've seen here in COVID-19 so far. And I think that's something that a lot of people may not be aware of. So looking back from year to year, cumulatively, the impact of COVID-19 on our children is far wider. And the CDC actually presented this data recently when we were discussing the vaccine in this 5 through 11-year-old group. And what was really, really compelling to me was that there have been, this change in our perception that COVID-19 now is among one of the top 10 causes of death in children in this age group. And if you look at that overall number of nearly 800, that nearly brings it to the second most common cause of death in children right now. So this is really, really something that we need to be changing our perception on and taking seriously for our kids. In addition, I did want to mention that there's going to be some other things that come up, right? Kids that are overcoming this infection have also been recognized to have some post-COVID conditions. There was a UK study which showed that there was a small fraction, about less than 10% of children who continued to have symptoms over 12 weeks after their diagnosis. And these are similar to adults. They may have fatigue, headache, insomnia, these types of things that really hinder their ability to go to school and to kind of regain their normal quality of life. And lastly, before I start talking about the vaccine, I did want to mention overall, there's been over 8,300 hospitalizations to date in this 5 through 11-year-old age group. We did talk about the disparity a little bit there that's seen amongst non-Hispanic Black children and American Indian, Alaska Native, and Hispanic children, as well as Miss C. So you guys have all probably heard about this multi-system inflammatory syndrome in children. This typically happens, 4 to 6 weeks after an acute infection, where these kids have fever and they may have some organ involvement with inflammation in their heart. These kids are super, super sick. And about 50% of all of our Miss C cases have been seen in this 5 through 11-year-old age group. So that's very, very important for us to consider. And then the impact of kids, missing school because of quarantine and exposures. This is leading to a lot of in-person learning time for these kids. So I'm going to shift now to talk about the vaccine in children. And I'm going to take you guys through some of the data. All of this is publicly available, but just kind of condense it to the most important parts so that it's easy to digest. So the Pfizer vaccine for this age group had been conducted sort of over the summer, but I want to take you through the study design a little bit more. These kids in the Pfizer study were given a third of the dose of the adult Pfizer vaccine. So if you've had that one, we usually get 30 micrograms. The kids in the study arm got 10 micrograms. And there were over 3,000 children in the study arm. These children were randomized 2-to-1, so there's twice as many children in the study arm as there were in the placebo arm, because we are in a pandemic and we need to really evaluate if this vaccine will provide protection. And so I'm going to take you through some of the immunogenicity data, which is just a fancy word for the immune responses, efficacy data, which means how many of the kids in the vaccine arm developed COVID-19 over time and how many did not, and then some of the safety data. So just to take us through the timeline of this, two vaccines are given in this series. They're given at the same interval time as the adult dose, 21 days apart. And then these kids in the study were monitored for serious adverse reactions initially after, and specifically reactogenicity. So what kind of side effects were they having immediately after the vaccine was given, after the first and second dose? They were continually followed, after both doses were given, up to at least 2 to 3 months. And they had several blood draws to check their antibodies and other parts of their immune system. And these kids are going to be continually monitored, as are all of the adults that underwent the clinical trials for up to 2 years. And so looking at the cohorts of the kids in this study, they kind of broke it down into 2 different cohorts. The data from this was from over the summer. They started enrolling the first group in June with a cutoff in September. The second group initiated end of August with a cutoff in October. And so when you think about vaccine trials, that's really important, because that was kind of when we were seeing the surges in Delta variant in kids. And so we have a very good sense of if these kids that got the vaccine or not were exposed to the virus, so we can make a good analysis from there. So just looking at the breakdown, because I think it's very important for parents to understand that the quality of a study depends also on the demographics, right? So most of the kids in this study were enrolled in the United States. Over 71% of them were in the US. But the study also enrolled in Finland, Spain, and Poland. Most of the kids in the study, 91%, had no prior evidence of COVID-19 infection. So that means they did not report an infection, but also they checked antibodies on these kids before they were enrolled and made sure they had no antibodies prior to enrollment. And what was really encouraging for me was that about 20% of these subjects had comorbidities. So we think of vaccine trials just enrolling healthy kids and healthy adults sometimes, but in this study, they included at least 20% of kids who had obesity, asthma, neurological disorders, congenital heart disease. I looked deeper to see if there was enrollment specifically of any children with underlying renal conditions. However, I did not find any data to show that just yet. So when they looked at the efficacy, they're looking at how many kids followed over time in the vaccine arm compared to the placebo arm developed COVID-19. And so that's how they get this number of a 91% for vaccine efficacy. When you look at the placebo arm, there were 16 infections and compared to 3 in the vaccine arm. And that's a really good number. I just want to say that is a very encouraging, positive number that we're happy about. And we often don't see these numbers in vaccine trials, especially in children. When we looked at serious adverse events in these children, it was very encouraging to see that no serious adverse events occurred. I repeat, no reports of myocarditis, no pericarditis, no anaphylaxis, and no deaths in the children. These kids, you know, they're 5 to 11, so they're getting into all sorts of things. And because they're part of the vaccine trial, they have to report anything that happens. So interestingly, several of these kids, you know, got a spider bite, or they got a knee infection, or broke a bone. But of course, these are not considered related to the vaccine. And I also just wanted to highlight that we have very good pharmacovigilance and safety monitoring in place for this vaccine in kids. I will highlight the fact that this vaccine has been studied more than any other vaccine in the history of time, as it's been given to adults and in kids now as young as 12 before the study. So that is really, really, really encouraging news. But of course, we will continue to monitor these children as they start getting the vaccine. And just for parents that are interested in having their children get the vaccine, you know, there's several vaccine monitoring safety sites that you can report to if on the off chance something does happen. These are all some of the avenues that you can report to. Just to talk a little bit about the formulation. This vaccine in the 5 through 11-year-old group is completely different in the sense that we don't have those restrictions with freezing as we do with the older children. And that's because they have changed the formulation of the diluent that the mRNA is in, and it can be stored in a refrigerator for up to 10 weeks prior to use. And this is really helpful because we know that kids are going to be most comfortable getting this vaccine where they normally get all of their vaccines in their pediatrician's office. So this is going to allow for pediatricians to provide this vaccine the way they would other vaccines in their practice. Just to recap, this is a really good slide just to kind of remember the dosing is different, 10 micrograms in the younger kids compared to the 30 in the 12-year-old group and older. Just how many doses per vial are here if there's anyone in healthcare on the call. Lastly, right now in the 5 through 11-year-old group, we do not have any recommendations for an additional primary or booster dose. I know in immunocompromised children, 12 and above, they have recommended these children get an additional booster or an additional primary dose. However, we still don't know how these kids are going to, have protective antibodies and their T cells in response to this vaccine. So that has not been recommended at this time. And so again, I will say if there's a child that's in between turning 11 to 12, they should get the dose that's recommended based on their age at that time. So if they turn 12 before the second dose, they should get the 12-year-old dose. This is an age-appropriate vaccine formulation that's regardless of size or weight, as opposed to other medications in kids. And then the myocarditis question has come up quite a bit, right? So I will say one thing about this is that the risk of myocarditis, pericarditis, and that kind of a thing overall, not because of vaccines, is much less in the 5 through 11-year-old group. It's highest in males 12 to 29 years old. And that being said, with the lower dose, many of us do not anticipate this being an issue with the younger children. One last thing, co-administration can be a good thing. We don't want our children to get behind on other routine vaccinations. And so I just wanted to put this here that the COVID-19 vaccine in kids can be given without regard to timing of other vaccines. They can be given on the same day. And so here are just some recommendations for injection sites being different and spaced apart and this sort of a thing. So, and this is how I would encourage parents, if they're interested in moving forward with it, to obtain the vaccine for your child. You can go to vaccines.gov and put in your zip code and put in vaccine options, which would only be the Pfizer for the 5 through 11-year-old group at the moment, and kind of search for where the local vaccine sites are currently for you. So summary and key points today. I did want to put this here because this is very, very compelling and important for us to bring everything home. When we looked at other vaccine preventable diseases and hospitalizations caused by those diseases and infections prior to their recommended vaccines, you can see that COVID-19 had around the same amount of hospital burden per 100,000 as influenza, varicella, chickenpox. And when you compare to deaths in this age group, 5 through 11-year-old, before we had recommended vaccines for meningococcus, for varicella, rubella, the deaths far outnumber any of the other vaccine preventable illnesses that we give routine vaccinations to our children for. So this is really, really important for parents that are on the fence about this. Lastly, just to bring everything home, in the 5 through 11-year-old group, there have been over 1.9 million cases, over 8,300 hospitalizations, over 2,300 missed C cases, and 93 deaths. And so we know now that COVID is a vaccine preventable illness, and it is something that's only going to end because of vaccinations. And I'll leave you guys with these references. All of my slides have been borrowed from this public data and information that's available to you for you to look at in depth if you're interested in learning more. Thank you.
Thank you so much. Thanks so much, Dr. Priya. I will let Dr. Kirk Campbell take it over now.
Yeah, thanks so much, Kristen. And I'll be talking a little bit more about COVID-19 and kidney disease before we get into the Q&A. We certainly know at this point that chronic kidney disease, and that would of course include glomerular disease. Those are major risk factors for having severe COVID-19. We saw a lot of reports regarding comorbidities, including hypertension, diabetes, obesity, that would increase the risk of hospitalization, right, and poor outcomes. But really within that is chronic kidney disease. And of course, there's a lot of overlap because diabetes and hypertension are the two main causes, right, of kidney disease in the US. So, patients with kidney disease are uniquely susceptible to poor outcomes with COVID-19. And we know that there are other social and demographic factors that impact the risk, which would include, patients in crowded situations, close physical contact, and closed space. And as we look at some of these social demographic factors, we think about the higher burden of kidney disease among patients with lower socioeconomic status, and also patients who go to in-center hemodialysis units, right, where they may come in contact with patient staff, and certainly during the initial peak of the pandemic, we saw a pretty high prevalence of COVID infections among our dialysis population. And I think as Dr. Soni mentioned, patients from underrepresented groups are certainly more susceptible as well, with a huge disparity in the clinical burden of disease faced by those individuals. So, we also have become aware that there are patients with genetic susceptibility, including patients of African ancestry with apolipoprotein L1 gene mutations, who can get pretty severe acute kidney injury. And I think this is one of many case reports. This one was from Tulane University, reporting on 6 patients who developed a collapsing glomerulopathy, which is one of the more severe phenotypes in the glomerular disease spectrum. And this included, 4 patients who required dialysis, and 2 patients unfortunately passed away. And we also had a case report that we published here at Mount Sinai of a patient with no prior history of kidney disease, who also had this genetic susceptibility to APOL1 high-risk alleles, and again became dialysis dependent. So I think not just patients with underlying chronic kidney disease or glomerular disease, but individuals who may have no prior history can get a severe acute kidney injury, after a COVID infection. And so, just a summary slide from a manuscript published last year in Nature Reviews Nephrology. There certainly was an appreciation that patients on dialysis or who had a kidney transplant had an increased SARS-CoV-2 seroprevalence and increased risk of mortality. And then on the acute kidney injury side, this inflammatory cascade, leading to, of course, a severe pneumonia and, dehydration, and that constellation of clinical findings can increase kidney injury. And we also found that when patients have acute kidney injury, that can actually increase the risk of mortality in the hospital. Patients with acute kidney injury are more likely to require intensive care unit level care, for example. And a lot of these patients did not fully recover their kidney function even after successful outcomes, facilitating discharge from the hospital. A lot of patients were left with residual chronic kidney disease. So, again, older age, hypertension, diabetes, the classic risk factors that we think about in associating the risk of severe outcomes with COVID-19 certainly apply in the kidney space. And again, when patients have a lower baseline kidney function, they're certainly at higher risk. And what we're trying to get a better understanding of is this impact on residual kidney function decline, and getting a better understanding of this new entity that we're seeing now with COVID-associated chronic kidney disease, right? And of course, this is not something we necessarily anticipated, when the pandemic began, but we are seeing more and more patients who have decreased kidney function after, getting COVID-19 related disease. So, just touching a little bit on the vaccination story, nephrology and kidney disease, patients with kidney disease have been traditionally underrepresented in clinical trials. I mean, on the left was an article from my colleague, Steve Koka, looking at the percentage of studies in the cardiovascular space that excluded patients with kidney disease. And at that time in 2006, it was about 56% of published cardiovascular trials that excluded patients with kidney disease. Unfortunately, that trend has continued. And this is data from the Pfizer study, and really less than 1% of patients in that study had kidney disease, right? Minuscule numbers. So we've been really, unfortunately, left to rely on real world experiences to better understand the response, right, to the vaccine in terms of efficacy as well as safety. But, of course, in a pandemic, we want to encourage all our patients to become vaccinated. But, we now are getting some information after the initial emergency use authorization and approvals that we can speak a little bit more clearly about the safety and efficacy of these vaccines in patients with kidney disease. So, a little bit of unfortunate news is that the antibody response for patients on dialysis and who have a kidney transplant is less, right, than the general population. The T-cell response is better, and that matters because the T cell response may decrease viral replication and can still, patients can still have some degree of protection even if they don't have a very robust antibody response. So I know that that's one question that always comes up, and there is some evidence that immunity can outlast, right, the antibody titer, for example, right? We can talk more about that in the Q&A. So this was one other study, again, comparing patients without kidney disease to patients on dialysis, as well as patients who've had a kidney transplant. And you can see here when measuring the antibody response, patients on dialysis, though the response is lower than control patients, it's still a lot better than patients who've had a kidney transplant. So, unfortunately, we're seeing that antibody response is lower, right, for patients with kidney transplants, presumably due to the immunosuppressive agents, right? And this is borne out in another summary that was published recently in KI Reports, where they looked at an aggregate of 35 studies in the published literature, and really trying to answer the question what the antibody response is across the spectrum of kidney disease, right? Patients with chronic kidney disease, and of course this would include some patients with glomerular disease, but they may be more classified in the immune-mediated kidney disease section, depending on the underlying disease, as well as dialysis and transplant patients. And you can see that patients with chronic kidney disease do have a significant response. 74% of them have a significant response, and patients on dialysis after 2 doses of the mRNA vaccines do have an 89% response, but again, lower for patients who've had a kidney transplant. And of course, as expected, patients who are on steroids or B-cell depleting therapies have a significantly reduced neutralizing antibody and anti-spike antibody response. And this is just some data from our dialysis unit at the Bronx VA hospital, where we found that patients on dialysis who have had a prior history of COVID infections in red do have circulating antibodies that remain, right? As a result, after 1 dose of, in this case, is a Moderna vaccine, there's an even more robust antibody response that's sustained over time, and even before the 2nd dose was administered, these patients already had sort of a maxed out antibody response if they had a prior history of COVID infection. However, patients in blue who did not have a prior history of COVID infections, didn't have this significant antibody response until at least a week after the 2nd dose of vaccine. So a little bit more similar to what we're seeing in the general population. So again, the antibody levels overall may be lower, but the kinetics are similar. And just the last couple of slides here, I think there's been a lot of discussion about some of the rare side effects and clinical observations with COVID vaccinations. And we have seen some very rare associations in the glomerular disease space. There have been several case reports about patients with minimal change disease and IgA nephropathy in particular, developing after COVID vaccination, sometimes after the 2nd dose, but also less frequently after the 1st dose. And it's still not well understood, could be epiphenomenon, but the time course in many cases does suggest somewhat of a relationship from a cause and effect standpoint. There's been some discussion around whether these patients may have had underlying undiagnosed kidney disease in this regard, and the vaccine, by kind of revving up the immune system, may be unmasking that. And I think that's one theory that's out there. But it's just something to be aware of, that there can be flares or an unmasking of previously undiagnosed disease. And I think this is just one summary recently published of the the number of diagnoses that were reported, again, mostly IgA nephropathy, minimal change disease, and 27 of these were in patients who didn't have a prior history of glomerulonephritis. So, again, just something to be aware of, and I think the risk benefit clearly favors, getting these vaccines, but also following up with the nephrologist for discussions and monitoring. So I think with that, I will pause as we will get to the Q&A.
Thank you so much, both of you. We do have a few questions. So Phyllis has asked if the viral load is different in kids than in adults. Dr. Soni, do you maybe have a response to that?
Sure. Great question, Phyllis. So yeah, just a little bit on the viral load. We don't, first of all, necessarily monitor or measure the viral load when we do a PCR test in children versus adults as well. However, there have been several studies that have looked at this question. Do kids shed more virus or not in comparison? It seems like they actually have more of a viral load in several studies that have been done. However, that does not correlate with their severity of infection. And so in adults, sometimes we can extrapolate that, if there is a low cycle threshold, which means a very high viral load, that these adults may have a more severe course. We cannot make those same assumptions when we look at the viral load in children. And therefore, we don't really routinely do it at all, but it's a good question.
Great, thanks. She asked, she had a follow-up question. Well, not really follow-up, just another question around the percentage of, false negatives to false positives with testing for the virus. Can you share a little bit of information around the accuracy of some of the diagnostics that are being done now?
Sure. Yeah. So I think, especially with kids now being back in school, many schools are requiring even routine testing and this kind of a thing. By and large, the false positives that we're seeing in these testing modalities occur with antigen tests. Which are typically not, done all the time. However, they have more of a rapid turnaround. So in comparison to the PCR. So I would say that as a general sort of statement. However, there are some rapid PCRs, including, one called the Abbott ID Now that have had some increases in false positive rates. However, when you kind of combine with a patient's symptoms and put that all into context, that's how you should be interpreting these tests and thinking about them. But far and large, false positives are more seen with antigen tests compared to a PCR method.
And so with that, Dr. Soni, would you recommend that if someone needed to get tested, perhaps have had symptoms and they want to find out if it is COVID, if it's caused by the virus for COVID, you would recommend the PCR test?
Yes, I would recommend a PCR test. Now, people are testing left and right for all sorts of things, and asymptomatic testing done with an antigen test is more likely to result in a false positive. So if you have symptoms, go ahead and get the PCR test and arrange that with your provider. Great,
thank you for that. I have a question. Says, hello, my now 18-year-old son has minimal change disease with relapses when he has had the influenza vaccine several times. So he relapsed with influenza vaccine. He has had COVID without symptoms. So my question is, should he vaccinate against COVID or not? We don't want to relapse with high dose of prednisone. He is on CellCept, and if you take CellCept, is the vaccine less effective? Dr. Campbell, do you want to take that one?
Yeah, sure. No, it's excellent questions, and I think there is certainly a need to talk with your physician. I mean, I think that we are still not done with the pandemic, and the risk of severe outcomes with COVID. And the potential for new variants developing, that's always out there, right? So we do still recommend vaccination, right? Particularly for folks who are on immunosuppression, where the risk of poor outcomes getting infected is high, certainly, but also the efficacy of the vaccine, right, may be less, and there may be boosters needed over time. I think for some individuals who may have had a bad reaction to an initial vaccine, then the question is much harder, right? And that's a discussion again to have in conjunction with the physician. But I think again, just assessing risk and benefits. And so many unknowns with this virus, we really want our patients to be as protected during the pandemic as they can be, right, from COVID infection.
Yeah, I appreciate that answer. And Asa, I would add, as a nursing perspective, I hope that you will consider getting your 18-year-old son vaccinated. And when you do, I should say, it would be a good idea to just, dip urine, checking for protein in the urine. I would probably say, every first void of the morning for probably at least 7 to 14 days, and just see what it looks like, right? Especially if he's had a reaction or a relapse that might or may not be associated with a previous vaccine. Sometimes it's hard to track what causes some of these relapses, but definitely that would be a time to definitely monitor his urine for several days to make sure that he's okay, and communicate with your kidney doctor for sure. So
yeah, and the only thing I would also add is that we're also learning that the Moderna vaccine may have higher mRNA content, right? It seems to be more potent. So I think Dr. Soni presented a lot of data on the Pfizer vaccine, right, in children and young adults. And so, we have options now, right, for different vaccines being approved. And there's also the non-mRNA Johnson & Johnson, right? So I think getting some protection is important, and which vaccine, it could be the topic of discussion as well.
thank you for that. Dr. Soni, I'm going to ask you this one. Have there been studies on the efficacy of the third dose in transplant patients? Obviously, we're talking with a kidney group, but do you have any information on that third booster or that third dose in this particular group?
Great question. Many of these studies are currently enrolling, and several groups are looking at this now in terms of with the booster in our immunocompromised patients and transplant patients. What does that look like? There is some data coming out of Israel recently that is showing that there is even a better, longer response in normal hosts with the booster, or immunocompromised hosts with the booster, that may last 9 to 10 months. But what that looks like in a patient with a kidney transplant is still to be seen. And I would say, hopefully next time we talk to you, we could have more data and details on it. But unfortunately, I don't have very much to share at the moment.
Yeah, that's true. It seems like more and more research is being done, and we're constantly getting more updates. So that's a good point to make. Another person has asked, how should a nephrotic syndrome patient think about their risk to COVID? How does that differ from someone diagnosed with kidney disease but is pre-nephrotic syndrome?
Yeah, no, that also is a good question. Of course, it kind of depends on the stage of kidney disease, right? Comorbidities. I mean, I think that there's so many variables. It's not just how much protein there is in the urine, and we know that higher levels of protein in the urine, so the nephrotic syndrome, patients with nephrotic syndrome may have higher cardiovascular risk, for example. So one would assume that the risk of poor outcomes would be higher, right? But again, every patient is unique, and I would again consider that patients with nephrotic syndrome should consider themselves to be high risk, especially if they're on immunosuppression for COVID infections, and really monitoring themselves after the initial vaccines for the need for boosters because of a lower efficacy, particularly if on immunosuppression. So I'd really think about it in that sense. The overall health and risks for hospitalizations would be higher if you have higher levels of protein in the urine. Absolutely.
Yeah. So a common theme that I see kind of coming up in some of these questions, and even in some of the questions that we got from our patient community prior to the webinar, is really around common treatments, common medicines that our community is on. So for instance, there's a question here that says, is there a diminished immunity response when a patient is on prednisone or tacrolimus? I know that that this has also come up with, what medications maybe reduce that antibody or immune response more than others, and maybe could you answer some of those around the medications that we take?
I think, yeah, I'll have Dr. Soni chime in, but we certainly, in some of the meta-analyses that have been done, certainly B-cell depleting therapies, rituximab, and agents like that have been sort of higher on the list, right, for a diminished vaccine response. But certainly steroids have been implicated as well. I think that calcineurin inhibitors and like tacrolimus and as well as MMF, are also immunosuppressive and have been associated as well. And maybe a part of the reason we think, right, that specifically patients with kidney transplants, as we mentioned before, have a diminished T-cell response and antibody response to vaccination. So all the commonly used medications that are mentioned, I see a lot of them in the chat, right? Steroids, MMF, tacrolimus, these are associated again, right, with a diminished response.
So I'm going to ask you a couple of questions around treatment options. So if there is a known exposure to COVID, or perhaps there is a positive test, the patient is symptomatic with COVID-19 disease, what kind of treatment options are out there for the patient community? And there's a lot of questions that we've also received around monoclonal antibodies, what other kind of treatment options, and do we try to treat patients at home if possible, or do these patients always need to come into the hospital for closer monitoring? Dr. Soni, do you want to start first with the pediatric area?
Sure, absolutely. So I will say, in our experience with therapeutics in kids, it's been quite limited, right? We're sort of extrapolating from the adult experience and making sure that we are providing treatments if necessary to vulnerable kids in a safe way. So in terms of like a monoclonal for a child that's immunocompromised, immunosuppressed when they do develop COVID-19 infection acutely, that is something that we can provide, but it's not a readily available treatment in kids less than 12 years of age and less than a certain weight. So that's something that, I've had to do from time to time in very high risk patients, but it requires special approval from the FDA, from the company. And so it's sort of a process, but in terms of the monoclonal, there were two sort of options of this. And now we're relying heavily on the Regeneron cocktail that includes casirivimab and imdemivab. So those two combined are more protective against the Delta variant strain. And it's something that we can provide where kids may not necessarily need to go into the hospital, but could have this infusion provided in the emergency room or in a clinic. And then that would limit their sort of propensity to have severe disease.
Thank you. Dr. Campbell?
Yeah, I actually had one slide on this that I skipped in the interest of time. I don't know if you want me to pull it up.
Yeah, for sure. Yeah, absolutely.
Yeah, it's just a very brief overview, just to summarizing the different options, right? So yeah, there are antivirals out there that kind of reduce viral prevent the virus from multiplying, and anti-inflammatory agents can certainly, and I saw a question about prednisone, and of course what we use is dexamethasone, right, to kind of reduce the inflammatory response that can be quite pathogenic. And of course, as Dr. Soni mentioned, the monoclonal antibody treatments that can really prevent the virus from infecting you. And I think the antivirals and the antibody treatments are not really given to hospitalized patients. I mean, these are meant to be given earlier, right, after an infection to kind of diminish the need for hospitalization and poor outcomes. So I think those are good options to potentially reduce the need for hospitalization.
So the antivirals, does that include the Merck and Pfizer oral medication that is coming out or that has gotten out now?
Yes, and I think, Dr. Soni can certainly speak to that, but, there's been an application for emergency use authorization. I think, other countries have moved a little bit faster, but the idea, yes. And I think we've had antivirals available, right, for influenza for some time, right, which we know can shorten the duration of symptoms. So it's and some of these agents that are subject of EU have been developed for influenza treatment and are now being repurposed for the COVID space. So yes, the idea it would be an oral agent that you could administer to prevent the need for hospitalization.
Yeah, one more question. We're almost out of time today. Emily has asked, media has put out about mixing and matching different vaccine brands. Do you suggest for this community, it's okay to get the different types of COVID boosters, or do you recommend staying with the same vaccine brand?
Great question. I really like this question because we had some interesting data come out from the UK when they started mixing this. And that's kind of how we've started to make some of the similar recommendations. So if you had gotten a Johnson & Johnson for your vaccine, I 100% think it would be a great idea to mix with an mRNA as a booster if you're eligible and able to get it. Moderna or Pfizer, either or. However, if you had been getting, or if you'd gotten the Pfizer or Moderna for your primary, it does not matter either way to get, stay within the same for your booster or to get a different mRNA booster. We may find out more about this. There's this theory of filling in the Swiss cheese holes by getting a different version of the mRNA booster, but I still don't have any definitive data to recommend that per se. So if you've gotten Pfizer as your primary and you're eligible for a booster, or your child is, I would say either Pfizer or Moderna is perfectly fine.
Thank you so much. And just to conclude today, I want to thank everyone for being here. Thank you to our speakers for presenting this wonderful update to us. I want everyone to remember the big takeaway is that COVID-19 disease is now a preventable disease based on vaccines. And the evidence shown here today definitely has shown me that the benefits of getting the vaccine outweigh the risk of harming your kidneys or causing further problems with your particular kidney disease. So thank you so much for being here. Reach out always. I'm here at NephCure.org. You can email me at khood@nephcure.org, and we'll see you next time. Thanks so much, everyone.
Thank you for having us.